Hello and welcome to this podcast by the Podmedics. For other similar podcasts, supporting materials and book reviews, please visit www.podmedics.co.uk. So hello and welcome to the first of two podcasts on arrhythmias. This is a topic that many students, including myself, find complex, but is actually quite simple as long as you understand the basic pathophysiology and remember a few of the simple treatments. In this podcast, I want to look specifically at bradycardias. To this end, I'm going to talk about the common presentations of bradycardias, the different features on an electrocardiogram that allow you to diagnose them, and then finally consider some basic treatment strategies, focusing particularly on the ALS bradycardia algorithm. So, the bradycardias present in a number of ways, going from being totally asymptomatic to sudden death. The most common presentation, however, to remember is the Stokes-Adams attack. From a pathophysiological point of view, this represents an episode usually of sudden onset where cardiac output is embarrassed to such a significant amount that patients lose consciousness. Patients or their relatives therefore describe sudden drop attacks with rapid recovery and pallor replaced by flushing. Remember, however, that bradycardias may also present with palpitations and milder degrees of dizziness. From a diagnostic point of view, if we leave the symptoms aside, bradycardia is a heart rate less than 60 beats per minute. Bear in mind, however, that young, fit individuals may be totally healthy with such a heart rate, and that this may also occur in healthy individuals during sleep. When considering the causes of any bradycardia, think of cardiac and non-cardiac causes. The most common cardiac cause is, of course, ischemia, particularly to the SA node or the AV node. Often, however, bradycardias occur in older patients with no history of arterial disease, and in such patients, fibrosis of nodal tissue is the most important pathology. The most important non-cardiac cause of bradycardia is drugs, for example, beta blockers and digitalis. The other important cause or set of causes are metabolic states, such as hypothyroidism and hypothermia. The concept of defining a number of degrees of heart block based upon various ECG features is the most common approach used to classify bradycardias. Heart block may be first degree, second degree, or third degree, and as a rule, the severity to the patient increases as we move upwards through this classification system. In first degree heart block, the PR interval is greater than 0.2 milliseconds, or greater than 5 small squares on the ECG paper. In second degree heart block, we define two important subtypes, Mobitz type 1 and Mobitz type 2. In Mobitz type 1, otherwise known as the Wenckebach phenomenon, there is, over the course of a number of beats, progressive lengthening of the PR interval, eventually leading to a dropped beat. After this, the cycle of progressive lengthening begins again. In Mobitz type 2, there is variable success of electrical conduction through the AV node, resulting in either 2 or 3 P waves per QRS complex. Mobitz type 2 is the first of the worrying bradycardias, as it often progresses to complete heart block. The last type of heart block to know about is third degree heart block, and this is most definitely serious. The ECG will show complete dissociation between P and QRS complexes, and this represents complete failure of conduction through the AV node. The rate will either be that of an infra-atrioventricular nodal focus, i.e. narrow complex and around 45 beats per minute, or a ventricular focus, i.e. wide complex and around 30 beats per minute. So those are the diagnostic basics. Now let's move on to basic treatments. If you look at the ALS bradycardia algorithm, a link for which can be found on the website, you'll see that the first thing to do once you have established that a bradycardia is present is to find out to what degree the patient is compromised by this bradycardia. This compromise may occur in a number of ways, but basically the most important signs of compromise are forwards cardiac failure, resulting in significant hypotension with a systolic blood pressure less than 90, or a reduction in consciousness. Alternatively, there may be backwards failure, leading to pulmonary venous congestion, and you will therefore hear with your stethoscope bibasal crepitations. If patients are compromised, then they need treatment. If they are not compromised, the only other situation in which they may need to be treated is if they have one of a number of dangerous rhythms that have a high risk of deteriorating. These include, as you might have guessed, third-degree heart block and Mobitz type 2. Two others, however, to be aware of are an absolute heart rate less than 40 and episodes of asystole. So, let's say you've decided to treat. The basic idea, of course, is to speed up the heart rate. To achieve this, you can use either drugs or electricity. The most important drug, and the thing that is usually used first line, is Atropine. This is an anticholinergic drug with a short half-life that is given IV at a dose of 0.5 milligrams. It can be repeated up to a maximum dose of 3 milligrams in the acute setting. Being an anticholinergic, its side effects, as you'd expect, are things such as dry mouth, blurred vision, constipation, and urinary retention. If treatment with atropine fails, and often it does, the next thing to do is to pace the heart. This can be done externally through beating the chest with one's fist. However, this is both unpleasant for the patient and the doctor and is rarely successful. Thankfully, there are two better methods. You can pace the heart externally using transcutaneous pads that are found on most defibrillators on the ward. This is effective, but is a little unpleasant for the patient as the current passed between the pads causes intercostal muscle contraction and hiccups. So the last solution in the acute situation is to internally pace the heart, and this is usually the best option. Internally pacing the heart basically involves inserting a rather wide bore central line into either the jugular or subclavian veins, and then passing an electrode into the right ventricle, where it is able to apply electricity to and pace the ventricle directly. A definitive pacemaker can then later be implanted. Note that the definitive pacemaker is also the option commonly used for patients with symptomatic bradycardias that do not need to be treated acutely. So that just about completes this podcast on the basics of bradycardias. In summary, bradycardia is defined as a heart rate less than 60 beats per minute and is usually due to failure of either impulse generation within the SA node or impulse conduction through the cardiac electrics. Important blocks include first, second, and third degree, and second degree can be divided into Mobitz type 1 or Mobitz type 2. In treating the patient acutely, the most important question to ask, or the most important questions to ask are 1. Is the patient compromised? And 2. Do they have a rhythm that is going to compromise them imminently? The most important treatment modalities are 0.5 milligrams of atropine IV or internal or external pacing. So that's about it. Thanks for listening and see you soon. Thanks for listening to this podcast. Please visit our site at www.podmedics.co.uk for more podcasts and additional supporting materials.